Hello, I'm David Kerr, Professor of Cancer Medicine from the University of Oxford. I'd like to discuss today a trial that's popped up recently in JCO, the FOxTROT trial. This is a trial of neoadjuvant chemotherapy versus conventionally adjuvant chemotherapy in patients with colon cancer. This was conducted from Birmingham, a sort of bunch of old muckers of mine from 1,000 years ago. The trial was started in 2008. They recruited around 1,000 patients, with the trial finishing recruitment in 2015. So a rather prolonged period of trial recruitment and quite a long period of follow-up between the trial finishing recruitment and being reported now. It was a 2-to-1 randomization in favour of the experimental arm, in which patients were given 6 weeks of neoadjuvant chemotherapy. So that's 3 cycles of FOLFOX, 48-hour infusion, 5-FU oxaliplatin, followed by 18 weeks of FOLFOX, or in the control arm, it would be 24 weeks of FOLFOX, 12 cycles at intervals of 2 weeks. The chemotherapy description I found a wee bit confusing, because at one stage they were considering a 2-by-2 randomization in which some patients got panitumumab, and it looked as if some patients could get capecitabine and oxaliplatin. So that would be 2 cycles of Capox, capecitabine, oxaliplatin, given at 3-weekly intervals, and the remainder given subsequently. So a bit of confusion and a wee bit of jumble around a particular type of chemotherapy. The panitumumab didn't add anything, but the key finding from this study was that the 2-year recurrence rates were around 17% in those patients who received the 6 weeks of neoadjuvant chemotherapy, compared to around 21.5% in those patients who received conventional adjuvant chemotherapy. What was interesting was that there were some imbalances in the number of patients who had chemotherapy. This is because patients who undergo radiological, so trying to get stage of disease radiologically, I guess there will be under and over staging. There will be a degree of doubt, false positives and false negatives. And in those patients who undergo surgery and then receive full pathological, histopathological review, of course there'll be some patients who'll be found to be at very early stage T3N0, and in that setting it's quite possible that the clinician and patient would decide that chemotherapy wasn't in their best interest. So there's a mismatch in the number, and fewer patients getting chemotherapy in the adjuvant arm. 2-year survival is a slightly unusual figure, to be honest. Usually we look at 3-year disease-free survival, overall survival, and so on. With 1,000 patients, the trial wasn't powered to look at overall survival and so on. So we'll get this. So we get this sort of slightly unusual 2-year endpoint. But nevertheless, an interesting study, one that I think we need to see more data. The longer follow-up, it's surprising that we don't have more mature survival data, given that the trial was initiated in 2008. There are other studies looking at similar questions, and therefore there may be the possibility of meta-analysis. But an interesting study. And in our practice, we're not rushing to engage giving neoadjuvant chemotherapy routinely, far from it. But in those patients in which the surgeons feel that there is a question mark or a doubt as to whether they might be able to resect or not, we would aim to give 3 months chemotherapy up front before bringing those patients back to the multidisciplinary team for review, hoping that we would have converted borderline or marginally inoperable patients to a clinical situation which the surgeon felt comfortable with the possibility to dissect. One of the other things that always interests me is how do we better select patients there's no doubt that whether with neoadjuvant treatment, adjuvant treatment, that we're over-treating patients. We're giving too much chemotherapy for a relatively limited benefit. And with the advent of circulating DNA, with the advent of better tissue-associated prognostic markers, we must become better at selecting patients who will benefit most from chemotherapy, whatever the timing of it. With biopsies, that then introduces an interesting question about whether a biopsy in a neoadjuvant setting would be at all reflective of the primary tumour as a whole, and that therefore reflects the question of tumour heterogeneity. If we take a small bite or sample of the tumour at colonoscopy or whenever, how representative would that biopsy be of the wider tumour? We know from our own and other work that colon tumours are significantly less heterogeneous, for example, than lung cancer. And therefore, with 1 or 2 or 3 biopsies, it's possible that we would be able to sample sufficiently across the whole tumour to be comfortable with heterogeneity. So as we apply more molecular biology, better patient selection, we need to look at how we take biopsies and the number of them to reflect the primary tumour in that early disease setting. Have a look at the study and see what you think. Clearly the world's moved on since 2008. We've now shown that 3 months chemotherapy by and large is as good as 6 months. We have better biological markers of prognosis to individualize the early treatment of colon cancer. But have a look at the paper. Very interested in any comments, advice that you might have, how this will affect your own clinical practice. Would be fascinated to hear. Thanks for listening as always, and for the time being, Medscapers, over and out, and thank you.